We're honored to have as our next speaker, Dr. who has a plethora of event coverage experience in multitude contact sports, OHL, rugby, what else? Basketball, soccer, and works with Dr. Tim Rinsbacher with the Brampton OHL team, and I'd like to have that give a warm welcome to Dr. Rinsbacher. Thank you very much.
Before I start, I just want to actually thank Dr. Leon Dilworth and his team for inviting me here today and giving me the honor and the privilege of speaking to you today. So thank you for that. Before I start, I just want to go through the faculty presenting disclosure. As you know, my name is Dr. Leon Gold, and I don't have any other financial relationship with any other financial sponsors. And as far as disclosure and financial support, you probably already know that this program has not received any financial support and or in-kind support. And any conflict of interest noted in slides 1 and 2 have been reviewed along with presentation content prior to the conference for potential bias. Okay. So while I was sitting there in the back, I was thinking to myself that I remember having this conversation with a colleague of mine who was a seasoned speaker on the lecture circuit. And he had said to me, you know what? There are 4 reasons why it's going to be hard for you to engage your audience. The first is if your presentation is after lunch. Right? Second is if it's in the latter part of the afternoon. Third is if it's on a Friday afternoon. And the fourth is if it's a non-dental group that you're speaking to. So I got a huge challenge in front of me, but I'm actually going to take the lead from Dr. Goulet and say, I'm going to flatter my audience by saying you guys have been awesome so far, so I'm sure we're going to change our narrative today. All right, so in your world, you are busy fixing knees, shoulders, elbows, getting people through their concussion symptoms, hamstrings, etc. In my world, I'm busy fixing or trying to fix smiles. Sometimes our worlds collide, and that's usually on the playing field or in the ice rink or basketball court, where an errant pass ends up on the face, or an elbow ends up knocking an athlete in the face, or just having an awkward fall. That's the time where your world and my world collide. And what you do, and that's when actually you become, instead of being the sports medicine specialist, or ER doc, or a pediatrician, you end up being the on-call dentist. Now, what you do in the next few minutes after you've seen that injury, or in the next few hours, is going to determine whether that athlete is going to keep their smile forever, or is going to be forever trying to fix their smile. So, sticking with the sports theme here, I'm going to say to you that today, you and I, hopefully, will add a new chapter to your sports medicine playbook. And we're going to look at identifying these injuries and as well as managing them. So as you know, we're going to be talking about dental trauma in the pediatric sports population. Looking at the scope of the problem. So we're going to go through the scope of the problem and the prevalence, move on to just a little bit about protective equipment, and then right after that go right into talking about the management of the different injuries. So, scope of the problem, the bigger number that matters to me is this one right here. 31.8% of the facial injuries in sports lead to dental trauma. The reason why that matters to me is that for all intents and purposes, either the severity or the incidence of that trauma can be limited by just having proper protective mouthwear or a mouth guard. Okay, so things that you may not be aware of is that high-risk sports by age, baseball leads injury stats ages 7 to 12, basketball ages 13 to 17, and then of course we all know about hockey and field hockey and so on. And again, another thing that's of interest is that vulnerable population is typically children under the age of 7, and it tends to be more prevalent with boys. All right, so why are pediatric athletes more vulnerable? The first thing is really the developing dentition. When we're talking about developing dentition, we're talking about the alveolus, the maxilla here, not fully developed yet because it's still, not dense enough. You're looking at teeth that have open apices or open apex, or sometimes you're looking at teeth where the primary teeth are still there and the adult teeth are still underneath developing. And then, of course, you know about the limited awareness and injury mechanisms. Those are, children in general tend to be less coordinated, so a lot easier for them to injure themselves or others. And the long-term impact is when the vulnerability really makes a big difference. Beyond the immediate pain and trauma, the psychological effects, the social effects, as well as, the mental trauma that they go through tends to get quite difficult for these patients. And if you're looking at the financial costs, it could go up to $20,000 to simply replace one tooth. I'm going to share a little story with you. I unfortunately don't have the pictures to share with you, but I think this is going to drive the point home. Several years ago, I had on a Saturday afternoon, I had this mother bring in her 5-year-old son, and when I examined him, he was missing 4 of his primary incisors, and he had all kinds of soft tissue trauma. And I said, "That's what happened." And he said, little Johnny here was playing basketball, and he slipped and fell face first. So they took him to the Sick Children's Hospital, and at that time they fixed him up. They removed the incisors because not only were they damaged, but they were intruded. Long story short, there he was at age 5, missing 4 of his front teeth. Now the issue is that the adult teeth don't come in till about age 7 or 8. So till then, he walked around with no front teeth. So you can imagine the social or the emotional or the psychological impact it has on that child at age 5. Now it gets worse. Age 7, the adult teeth start to come in. And instead of having 2 central incisors, he had 1 central incisor, or rather, there were 2 that are fused together, creating a little point, like almost looking like an arrow. And he got his lateral incisor. So now, and this happened because of the trauma he sustained. The 2 teeth ended up fusing, the 2 central incisors. Now, after so many years, he's 16 now, we finally kind of got his ortho done, and now we're looking at potentially having to extract that 1 weird-looking tooth. And then after that, we're looking at putting 2 implants in. And those implants probably won't replace till about, around 23 or anywhere 23 to 25. Because now we're finding that it's actually better to delay the implant placement. So this child, from age 5 to potentially to age 25, is going to suffer through all of these different things that we talked about. So obviously where I'm going with this is prevention, the power protective equipment. As you can see from my slide, that 60 to 90% of the dental injuries can be avoided or reduced by, wearing a mouth guard. There's already, in sports, football, ice hockey, lacrosse, field hockey, wrestling, these are all, the mouth guards are mandated. But other sports such as basketball, soccer, baseball, to name a few, don't really have that mandate as far as mouth guards are concerned. So it's something to think about, but again, obviously, this is the time I get on my soapbox and say, given what you've heard from me, and when you see this on a regular basis, you feel really bad, and you feel like, you know what, maybe a little bit of education could really help this athlete. So, speaking of protective equipment, we're going to talk a little bit about the right type of mouth guard for pediatric athletes. I'm going to start off by saying any sort of mouth guard is better than no mouth guard. Okay, that's the first thing. But I will also say that the stock mouth guard is probably the one that you never, ever want to use unless you absolutely have to. Okay? So when we talk about custom mouth guards, we're talking about mouth guards that can fit in a way so they're comfortable, okay? And because they fit so well, they tend to stay in the mouth better, which allows for the athlete to be able to breathe better rather than having to clench their teeth down so that, the mouth guard doesn't fall off. So there's, that advantage. Now we put down a reduced concussion risk, but I want to clarify that mouth guards do not prevent concussions. And when we talk about concussion risk, we're talking about mostly impact that's coming from the bottom here, as opposed to anywhere else, as you know from our previous lectures, that concussions can be multifactorial. Boil and bite mouth guards are great and for a short-term solution, or if you need something in a pinch, it's affordable and it's moldable. But what happens is because it's moldable, it doesn't quite have a uniform thickness. One thing I forgot to mention that when you're looking at custom mouth guards, because they're custom made, they can have a uniform thickness all the way around. And we make it so that we're actually covering the maxilla or what we call the mucobuccal fold to also ensure that the trauma they'll get some protection on the alveolus as well. So we know, for instance, that if you have a 2mm mouth guard with uniform thickness everywhere, it can reduce impact by anywhere from 50 to 60%. And if you have a 3mm mouth guard, then it can reduce the impact by about 86%. So having that uniformity of the thickness is really important. But unfortunately, with boil and bite mouth guards, that's exactly what we end up losing. So this is what a boil and bite mouth guard looks like after it's been formed. And you can see that it's quite see-through right around here. So it's really offering no protection when it comes to the biting surface. Okay? Whereas you can see that this is a custom-made mouth guard, and you can see that there's uniform thickness and it's actually molded right around the teeth perfectly. All right, so let's talk a little bit about what athletes are most vulnerable. First is the patient with that large overjet. We always say that the teeth walk in before the athlete does. That's the kind of patient that is most vulnerable. Why? And what we also know is that if you're looking at overjet, that's what we call an overjet, where the anterior teeth in relation to the lower anterior teeth. Well, we also know that if you have, or if an athlete has more than 3mm of overjet, then they are 3 times more likely to sustain a dental injury. Okay, so these guys tend to be quite vulnerable. Patients have what we call an anterior open bite. So as you can see, these teeth don't connect together anteriorly. That's called an open bite. And main reason for this and why they're vulnerable is the fact that what happens is that we don't quite have the lip coverage, which can act as a sort of a barrier when it comes to the impact. The type of patient that you're going to have or athlete you're going to have is one that has orthodontic brackets. Now, injuries that we see here are a little bit different because what happens here is There tend to be more soft tissue injuries just because of the impact and what it does to the soft tissues. And sometimes it's because the wire breaks and it starts to poke into the cheek or the lip. But what's interesting about these type of patients, you see less of avulsion injuries, meaning a tooth that comes right out of the socket. And you can see why, because the wire keeps it all intact. And then you have an athlete like this. And these are the ones where we say they're athletically gifted, but dentally vulnerable. Okay? So what type of injuries do we normally see on the field? Tooth fractures, they can be anywhere from complicated, coronal fractures to something very minor. Luxation injuries, these are, again, we'll go through all of that when I show you the management, are usually injuries that are, where the tooth hasn't come out of the socket, but has been moved. And then the avulsion is where the tooth has actually come out of the socket. And then the jaw fracture. So when we're dealing with dental trauma, this is now sort of the heart of the presentation. When we're dealing with dental trauma, what do we do and when do we do it? All right? So my ABCs here are a little bit different. They're more dentally related, and they refer to alertness, bleeding, and the care. So I'll go through each one separately. And forgive me for this, it's just because this presentation is also that I tend to give to my dental colleagues, so we do it this way. Alertness, I'm not going to dwell too much into this because this is your domain, this is what you guys do best. But really you're looking, other than looking for signs of concussion or dizziness or responsiveness, the other thing that I urge you to do is to consider in asking these questions, what was the direction of the blow or the impact? And where was it? The two things. Because that's going to help, in terms of the dental side, it's going to help us decide, or you decide, whether you're dealing with any dental injuries after this. All right. So the next thing is bleeding. For us, when it comes to trauma and in sports, bleeding is actually a significant component. So when we see bleeding, we know there's trouble, okay? Irrespective of where it's coming from. So, main thing is obviously you're looking for bleeding in the mouth. And when you're looking for bleeding in the mouth, you're looking for any sort of swelling like hematoma under the upper lip or in the floor of the mouth, because those are significant as far as considering, the fourth one fracture or a mandibular fracture. Bleeding, let's go back. Sorry about that. And bleeding or fluid from the nose, as you know, I'm not saying that it's always the case, it could just be a nosebleed, but you also want to then look at the possibility of a left forward tooth fracture. And then if you're looking in the mouth and you see bleeding there, then you're looking for where's this bleeding coming from. If you see a laceration in the gums, then again, you're thinking that there may be a much more significant trauma. And if you see, and the last thing that I always tell everybody is check the tooth. Now, if there's bleeding coming from within the tooth where the fracture was, then you know that this is something where which you need immediate help. The care. Why this is important is now that this chaos has happened and there's a kid on the ground and parents are there and it's crying and everybody's kind of looking around what to do and you're managing the situation, probably that's not going to be the time where you're going to be able to kind of, go look for that missing tooth if the tooth is avulsed. So this is the time when you want to be able to tell a responsible adult that you were there, hey, could you please see if you can find this tooth? And by the way, if you do find this tooth, then can you please make sure you hold it by the crown and not by the root. You're also looking for misalignment of teeth because that's telling you that there may be significant trauma in terms of luxation. And the last thing is, if you see that they've had coronal fractures, try and look for those pieces. I know that it sounds crazy, but really, it's very, very helpful to us when we see them after. All right, so quickly going through the intraoral exam. you're gonna be looking at soft tissues, and then we talked about the hematomas, but the next thing I'm gonna talk about is palpating the gums. It's really important to do that, because often what happens is that if there's been any subluxation, there is a resulting fracture of the alveolus. And you will feel that by just running your finger along the gum line, that you'll be able to feel that, yeah, I feel a bony ridge there, probably there's a fracture, okay? Then the next thing is, again, we're talking about intraoral, now what you're gonna see in the mouth. You're looking for bleeding from the periodontium, or the sulcus, we call it, in which case that's telling you that obviously there's either been a concussion or a subluxation of that too. And the last thing, of course, as I mentioned before, is checking for displacement of teeth. And a lot of times, you may not even notice it, but the athlete's gonna say, I can't put my teeth together, I can't bite together, because something has happened with the movement of these teeth, and as a result, they cannot get the posterior teeth to connect. I just wanted to put this in. These are obviously things that you're probably much better aware of than I am. But in my world, one of the things we look for is, when it comes to sinus mandibular fracture, is how's the bite? So the first thing that I always ask is your bite okay? Like, if everything else looks fine, how's the bite? Can you get your teeth together? Did they connect the way they always did? And if the athlete says no, then you know that there may be an issue with fracture. The other thing, obviously, is any one of these other items, such as unilateral open bite or paresthesia. One other thing that I want to mention to you here is that we'll often see that an athlete will come out of the field and they've got a hematoma or a bruise on the chin. And if you know about the impact or the direction of the impact, you do need to consider that then you may be dealing with a condylar fracture as well. As the impact comes this way, you could end up fracturing the neck of the condyle. So this is what you could potentially end up seeing on the field. And this, again, as you can see, is an anterior open bite, or what we call a unilateral open bite, where these teeth on the right side do not connect. And the other thing is that laceration of the gums. And any one of these things should alert you to the fact that there's a broken jaw involved. And this other issue here of these teeth separating. In the maxilla, again, one of the things you look at is the movement of the teeth, but you will also notice that, you start to get a lot of bleeding around here, which is indicative that you've had, probably a fortified fracture. Again, these are all injuries that I would consider as immediate. I wanted to put this slide up because I want you to just picture this for a minute as to what might potentially happen when there's trauma. So these two areas, pictures here are the ones that I want you to focus on. This one potentially leads to that subluxation type of injury that you saw in the earlier slide. And this one here relates to, again, you can still have movement of the tooth, but also a fractured root. These, again, depending on the level, and I don't want to go into details about how they get managed, but the point being is that even if the athlete says, I'm fine, you do want to consider that they may need some immediate help. Especially, pain is usually the factor. So, now we get to the type of injury that matters the most for you, okay? Which is the bulging. Now, as far as the management goes, so let's assume now some responsible adult did manage to find that tooth, and you're now ready to kind of look at it and go, and I'll tell you one thing right now, and I kind of joke about this, but that tooth has a home, and that home is not on a sterile gauze or a container of milk or Hank's Balance salt solution, which are all really good. It's in here. Okay, so you want to try your best to be able to put it right back in. So if you're going to do that, what I always say is, first obviously you're going to handle that tooth by the crown, and I'm going to show you some slides how that's done. And then the other thing is that you want to, rinse the root so that removed all the debris. And then you're looking at having to rinse out the socket where the tooth came out of. And then the third thing is you want to implant it in. And the critical timing, timing is critical, 5 to 10 minutes. If you do this in 5 to 10 minutes, the prognosis is really good. Now, previous studies have shown even up to an hour, you're in pretty good shape. But why I say 5 to 10 minutes is because we know that the success rate goes up significantly, okay? And then, of course, the next thing is once that tooth is in, it needs to be stabilized, so they do need to see a dentist right away. And the last thing I want to, because we were looking at from a pediatric standpoint, you never reimplant a primary tooth. Because there's an adult tooth underneath there that you may end up damaging in the process. Okay? So this is kind of what it will look like as you putting the tooth in. But I'll show you a better slide where you can see that, the tooth is being held by the crown, the root is being, rinsed off, and then it will be placed inside the socket. And I'll also show you one practical example of this. This is a young lady that, again, I don't mind saying this, my son actually was a resident at Mount Sinai, ended up seeing this young lady, and at 4 o'clock in the morning he phones me and says, Dad, I'm not sure how I should handle this. And I said, okay, let's, so he kind of took pictures and sent it to me. And what I'm saying is that this young lady lost 3 teeth, out of which they could only find 1. And remember, this is in the middle of the night, okay? She's distraught, family's distraught, everybody's going crazy. And they bring this 1 tooth. Great news though, they brought in a container of milk. So that really helped. Now, here's the problem. So my doctor, if I call him that, looks at the tooth and goes, well, I don't know. Is this a central incisor or is it a lateral incisor? With all the education we have in dentistry, he and I couldn't quite figure it out at that time. For me, my excuse is it was, 4 o'clock in the morning. Right? So my point is sometimes that's going to happen, but it doesn't matter. Just put that tooth in. Okay? So that's the point I want to make. The other point I want to make to you is the fact that sometimes, as you're trying to put this tooth in, you meet resistance. And it's like, okay, somehow the socket has collapsed there, and I just can't shut this tooth back in. In that case, one of the advice I, because this is 3 teeth, but what I would do is I would take a little hemostat, go in there and kind of just open it up a little to allow for that socket to expand, and then try and squeeze this tooth in. Okay? Just a little tip. And then once it's done, they ended up putting a splint there, and this young lady is probably going to end up needing 2 implants in the future. Alright, so we talked about Abel's teeth. I'm going to talk to you very quickly that there are 2 really good ways of trying to save these teeth if you cannot reimplant them. One is what's called saber tooth. This is what I said was the Hank balanced salt solution and milk. Okay? And this is just kind of the different characteristics. But the point here I also wanted to make was that do not use sterile water to store that tooth. Because what we know is that actually ends up causing cell lysis. So, not a good idea. Last resort, nothing else can be found, and at least use the saliva. Alright, so the next type of injury that we're going to see quite often is something called a coronal fracture. And with the fracture, there are really 2 types. It's what we call a minor or a complex fracture. Important thing is obviously that hopefully you're able to find that fractured tooth, save it in the sterile gauze, and then ship the athlete off to see the dentist. Okay? However, if you see a coronal fracture, I'm going to actually show you the next slide here. If you see a minor fracture like this, really it's not so bad and you don't see any bleeding inside where the fracture is, that athlete can go back to play if they're not in pain and they're comfortable. But if you see something like this, where you're seeing that little pinpoint area of bleeding, then you know that athlete should really be transported to the dentist. And sometimes when we see coronal fractures, this is what we see. This is an athlete that got hit in the face and we couldn't find the pieces. And then somehow somebody was astute enough to say, hey, why don't we look at that laceration? And lo and behold, both the pieces were in here. So, I'm sharing this with you as if you were to ever see that, at least consider that if you have a large laceration and broken, tooth, then potentially you could be looking at it being embedded in the soft tissue. And then sometimes you'll get this situation where this athlete came in and, with 2 pieces of his teeth in a baggie, that was still okay. And why I'm saying this is that, not to say that, we can rebuild anything, but we can end up putting it back together. So if you're able to save it and find it, as dentists, we will be very, very grateful. All right, the next type of injuries we're going to talk about are subluxations or luxations, and in which case then we're talking about intrusion, extrusion, and subluxations. All I want to tell you here is that if any of these type of injuries happen, they do need immediate management. Because typically, as you can understand, if there's been trauma and these teeth have been shoved up or brought down, you are disturbing the blood supply to the roots, and as a result, immediate management can potentially help to alleviate future issues. In an extruded tooth, this one I just wanted to mention to you that sometimes you'll get an extrusion just because of the impact, and the tooth will just drop ever so slight. In which case, and the patient won't be in pain. That's a situation where you may want to just see if you can kind of just gently push it back up. Be aware that if there's blood clot there, chances are that that tooth will come right back down. But nevertheless, at least that's something you can help for the athlete so they can get through the game. Okay, subluxation. So this is when the tooth has actually, moved, but not out of the socket. And you can see here that, that it can be bad enough that the athlete can bite down, so you have to address that for them right away. And I'm going to show you a technique how that's done, okay? And that's why I will say that attempt to place the tooth back in position if you can. And normally when it comes to primary teeth, you don't necessarily have to, because they will just, correct themselves in the future, usually, okay? But the only time for a primary tooth that you're going to address the subluxation if it's affecting the bite, which I'll show you in a second. So this is what you want to do and how you want to treat it. Is, as you can see, you want to put a finger at the back of the tooth and another finger where you can see where the apex of this tooth would be, and you're going to have pressure going in and down to be able to put that tooth back in. Okay? Subluxations, we know that you have a time frame of about 24 hours. If you don't address it in 24 hours, the tooth gets locked in, problem becomes much worse. So if you can help that athlete right there and then, that would be great. Okay, so this is us showing you, this is from Andreas in the textbook, showing you that, this is a pediatric patient that had to have the subluxation corrected. All right, so in essence, injuries that can be managed later are the minor enamel fractures. Primary tooth injuries, usually, they can be left till, next day sort of thing, and minor luxations. And as far as, and I had the slide up, I just thought, in case there's anybody who just wants a snapshot of what, how to manage these injuries, then it's up there for you. But as far as coronal injuries are concerned, when you see something like that, you definitely want to send them off, because 99%, the pulp is exposed. If you see something like that, maybe and you don't see the bleeding there, you could wait. And if you see that, definitely not a problem. I wanted to end with this case because, I'm so sorry, it is a graphic slide, but I'll just tell you. This is a player that we had, and, he ended up getting injured in the face and had a subluxation of these two teeth, very minor, but he also lost this tooth. He was one of our hockey players. And what happened is I did the splint here, and 2 weeks later removed the splint. That was on a Thursday, and on a Saturday I get another call from my colleague Paul Piccini, who said, "Hey, our guy is back. So give me time." Okay, go in there. This is what I met with, and this happened during a practice. So the moral of the story here is try and encourage your athletes to wear the mouth guard, even if it's during practice. Okay? Now imagine 4 hours later, this is the best we could do for him, but it was actually pretty good considering what we started off with. Okay? The moral of the story here is, as I said, encourage your athletes to wear a mouth guard even during practice. And the other is that despite your best efforts in educating and as well as giving them the best mouth guard, doing everything else, accidents are going to happen, such as something like this. Okay? So, again, my final slide, I promise, just wanted to bring this up to you that if you're ever interested in learning more about dental trauma, how to treat it, even on the field, and forget everything I told you and you need to pull up something immediately. International Association of Dental Traumatology has a really nice sequence that you can go through right in the field, okay? But the only thing I will say, heartfelt, is that I hope that you as physicians and those who take care of young athletes will encourage the athletes to wear mouth guard, educate the coaches and the parents for this protective equipment. Thank you. And I had to put this in because we wanted to chase some flowers, right?
Anybody have any questions? So just a quick question. A quick question just about the laceration. Sometimes you'll just see like a small gum laceration around it. Do you recommend repairing those?
Yes, because typically in the mouth, they do tend to open up a little bit more, and then you start to see infection and so on. And especially our athletes, for instance, they're never going to be very good and vigilant in keeping that area clean. So you want to suture it just so they're not left with a bigger scar.
So say primary teeth and there's just a little chip there, do they need to be looked at?
Not from the perspective of needing treatment, but you just want to make sure, because there's been trauma involved, then you just want to make sure you get an X-ray done just to make sure that it hasn't affected any of the adult teeth. But if it's something minor, then the tooth is going to exfoliate, especially if it's an anterior. It's going to exfoliate soon anyways.
When you say sterile water, are you saying like saline? Is saline okay? Or
Saline is fine too, yeah.
Thank you, that was very interesting. We'll worry
Well, thank you.
about it so we can understand. How frequently is a young adolescent needing to replace that custom mouth guard though?
Good question. So like when I'm doing mouth guards, I take into account when I'm expecting some of those teeth to be exfoliating. So I usually will kind of, or sometimes I'll have a child that the primary molar is already exfoliated if the adult tooth hasn't come in. So we'll make a mouth guard that will kind of have that space for that tooth to come in. So I always say to parents that you want to change this mouth guard every season because, teeth are changing all the time, erupting and so on, and maybe there's even a little bit of movement. So until the adult teeth are all in, I would recommend changing it every season.
Well done, so for a primary tooth that gets avulsed, is there a risk that you no longer have a splint for the secondary tooth and the other teeth will crowd around it?
There is that potential, but it also depends on the age. So let's say if this happened age 6, then probably won't be as much of an issue as if it happened when it happened in age 2.
If you can't rule out like a mandibular or maxillary fracture, but there is dental injury, would you suggest referring first to the hospital or directly to like the dentist urgently?
So based on the kind of the signs of what we would consider maxillary mandibular, if you don't see those, then there's still a potential there may be a hairline fracture. In which case then, yes, a hospital referral, but I would say probably just a regular dentist would be fine, because we would just take a Panorex and we should be able to tell. Because the treatment's not going to change at that point if it's a minor fracture, right? So I would say it's probably easier and better and probably less taxing on the system. And they probably won't be able to do a Panorex anyways.
From the emergency medicine perspective, if you see a dental injury like this, how soon after the emergency visit will you be able to get this patient seen and fixed?
Sorry, can you?
I was saying, if the patient presents to the emergency department with such an injury,
Yeah.
how soon are they seen and treated?
How soon are they seen by their dentist? I mean, that all depends on who's your dentist and what their hours are, really, because, like if one of my patients right now had an injury last night, I don't work Fridays, but nevertheless, if they left a message, I'd be there. So I think it all depends, but I would say most dentists are very, very, very accommodating when it comes to, traumatic dental injury. So I would say that they're probably being seen the first thing in the morning.
And some hospitals have on-call dentists.
Yes, and as from what I mentioned, that some hospitals do have on-call dentists, and if you feel that this is severe enough, then certainly I would consider sending them to Mount Sinai or Sunnybrook for just to at least have a look there.
Thank you so much.
Sorry, I took up a lot of time.